Thanks. So I've got the session just before lunch. I know everyone's hungry, so we'll try and get through this quickly. Just a quick talk really about bariatric surgery and basically the issues associated with it. Now, we spent the last 2 days talking about bariatric surgery, and really the take-home conclusion, which everyone can come to, is that bariatric operations are one of the best evaluated procedures performed worldwide. There's a really solid evidence base, there's nice guidelines, there's excellent short-term metabolic results, and very good long-term medical weight loss results. But there seems to be this odd paradox because we all know that it's the highest medical legal risk category. And in fact, you'll find that if you want to do private bariatrics and ask for a medical legal quote, it's now bespoke. So they will come and speak to you as they do for, say, the obstetricians looking after birth. So the reason that it's such high value is, I think, summarized quite nicely in this graph. This is a graph of the total CNST claims by speciality up to 2011. And you can see the biggest one is obstetrics and gynecology, hardly surprising because of the costs associated with problems during birth. But the second one is surgery. And amongst surgery, we know that the highest medical legal bill is for bariatrics, and that's reflected in the insurance. And just to put it into context, NHS resolutions say that the annual bill for negligence in the UK is 1.5 billion, and at the moment they are handling claims with a total value of 56 billion. So we're talking about huge sums of money, and really an awful lot of it, certainly in the general surgical aspect, is bariatric related. So we have this odd paradox that if bariatric surgery is so good, why are we seeing so much litigation? I think the answer is multifactorial. So if we actually look at the patients, I think an important factor is patient expectation. We've got a young and potentially litigious group. So if you look at most general surgical operations, and particularly the cancer operations, your average patient is age 70. That group of individuals tend not to go to the lawyers, and also, if we're being frank about it, have a shorter life expectancy. So an anastomotic leak in a 70-year-old post-colonic surgery is not likely to raise medical legal hackles in the same way that a potentially fit, overweight 30-year-old having a gastric bypass leak would. I think patient knowledge is also very important. Patients have lots of support groups. I think there is this notion that patients are very well versed in their operation. They're very happy to go online. And what that means, of course, is that if they have a complication, they won't suffer in silence. They'll be speaking to their colleagues, speaking to friends, speaking to people on support groups. And if they think something's gone wrong, they'd be quite happy to go and speak to a lawyer about it. And I think identity is important. Patients often identify themselves as bariatric patients. And because this is all related to weight, and people's weight is very much close to their sort of psychological build-up, if something was to go wrong with the bariatric surgery, they are more likely to basically try and seek redress because their hope, i.e. that weight loss surgery would make them thin, hasn't worked. And the big issue we've got now is rationing. We've got incredibly long waiting lists, and I think that adds to patient frustration. And you can imagine if you've waited 3 years for an operation and it goes wrong, you're quite likely to want to get legal redress. And similarly, if you've waited, say, a year and a half, you've paid to go privately, and then there's a problem or a complication, you'll be even more motivated to try and get legal redress. Amongst the surgeons, we've got to take some responsibility for why there are issues. It is a relatively unregulated market. There is no other general surgical procedure I can think of where someone can legitimately walk off the street and a surgeon is quite at liberty to put them on their list the next week. So, for example, if you had gallstones, you'd expect an ultrasound scan, i.e. you'll expect the patient to have seen their GP, had a scan, and then been referred across. Even a hernia, you need to be referred across by your GP. But literally, you could set yourself up as a bariatric surgeon and take someone off the street, and provided they fulfill nice criteria, you could arguably do their operation. There is this perception that the operations are easy. There's this idea that the operations are relatively straightforward, and part of us is our fault in our attempt, I think, to market bariatric surgery. We perhaps underplayed the complications associated with it. And that does mean that the surgical community in general regard bariatric surgery as a simple gastric band, but of course the reality is very different. And there's also this perception that there's a large untapped private market. So there is this perception that if a surgeon wants to build a practice quickly, the obvious place to go to is bariatrics because there are a large number of people out there who can be operated on. I think the other big issue we've got is with the hospitals themselves. There are a large number of providers, a large number of private providers with very minimal emergency cover. And that's particularly true of the privates. And I think Sanjay just talked about it. We also have this issue with overseas centres who offer surgery but not the follow-up. And obviously, if those patients have complications, again, they're quite likely to request litigation. Some of the hospitals do lack the specialist equipment. So, for example, a lot of the private hospitals will not have CT scanners, which can help patients over a certain weight, and that can be an issue. And there's often a lack of training associated with the specialists, such as CNSs and physios, and an awful lot of them don't have the experience of dealing with a very overweight patient, because, of course, particularly in the private hospitals, they tend to be more orthopedic-based, and they're usually operating on fit, young people of working age, as opposed to people with major medical problems. And I think the big problem really is the aftercare. This is a completely different paradigm to traditional resectional surgery. So if someone comes to you for a private appendectomy, the appendix comes out, you never see them again unless there's a complication. And that's really the private market for general surgery and orthopedics as well. But basically, you see the patient, you do the operation, provided there's not a problem, that's the end of it. Bariatrics, of course, very different. You do need lifelong follow-up. And the complications, things like internal hernias, can occur years after surgery. And these patients are physiologically very brittle. In other words, they may look like they're all right, but actually they are quite likely to drop off a cliff physiologically unless you monitor them closely. So before I did this talk, I reviewed my and my colleague Marcus Reddy's medical legal experience in the last 5 years. And I've looked at about 120 cases, which we've been asked to provide comments on. And we'll be presenting them at one of our meetings. But I think we should start with the positives. What we're seeing less of. So what things are we doing better as a community? Well, the first thing we're seeing less of is inappropriate surgical candidate. Certainly looking back over the last 5 years, an awful lot of the patients who were litigated ended up being inappropriate surgical candidates, typically having BMIs well outside NICE criteria. So we've had patients who've been offered sleeves with BMIs of 24, etc. We're not seeing that anymore. So I think the message getting out there is that we as a community are more picking appropriate surgical candidates. We're seeing fewer technical errors. Certainly when we first started doing this, we were seeing quite a few patients with roux en os, was a particular complication. We haven't seen many of those in the last 3 or 4 years, which again tends to suggest that we're getting better technically. And the big thing we're not seeing now is as many failures to rescues, because most of the litigation from the early years tended to be patients who had a complication, but then after the complication were basically not followed up appropriately and were basically turning up to A&E and being ignored because people weren't switched on to the potential seriousness of the complications. And though we still see some of them, these are becoming rarer. However, unfortunately, we are seeing now new trends. And one of the newest trends we're seeing now is a failure of consent. And one of the areas of litigation, which is we're seeing more and more of, is patients basically going to a centre and being told the centre does bands, or the centre does sleeves, or the centre doesn't do bypasses, having a complication associated with that, and then suing on the basis that they weren't referred to a centre which could have given them further options. And we will discuss this later. I've got some case examples, but I think it is now difficult, for example, to say to someone, our hospital doesn't do bypasses, therefore you've been referred to us, you will get a sleeve, when patients know that down the road there are other bariatric centres which could have offered them all of the options. Follow-up, I think, is now becoming more of an issue, and we're also seeing this question mark of what do you do about emergency provision? I think this is particularly true of the private sector. What is your pathway for emergency provision of patients who've had complications? And often we find that that pathway is not well written, it's not well documented, and that can be difficult to defend from a medical legal perspective. And the other question, which is we're seeing now, is the long-term follow-up. We've had quite a few cases of patients who've had nutritional deficiencies, zinc deficiencies, copper deficiencies. And again, the question is, were these screened for? Were the GPs informed about it? Did the surgeon think about it? And another slightly sad trend is we're seeing more and more litigation against non-bariatric surgeons. So a common area now we're seeing is patients admitted as an emergency being managed in an NHS hospital by a non-specialist surgeon and having issues and complications with that, and litigation taken against that surgeon, either for making management errors or for not contacting a bariatric surgeon in the first place to take advice. We're seeing litigation against GPs, particularly in the area of follow-up, and particularly nutritional follow-up. And we've now seen litigation against nurse practitioners, particularly people who have had band adjustments, where the band adjustment has resulted in damage to the port. We're seeing quite a few cases where people are suing the CNS who did the band adjustment. And we're beginning now to see the beginnings of what I call systemic institutional failures. So we haven't yet had a case, but I suspect it's going to come where someone is going to sue because they've not had access to surgery. In other words, they've fulfilled nice criteria, but the local CCG hasn't funded them. Now, there hasn't been a test case yet, but I suspect that will come, where people will say, I fulfill nice, but I'm not being funded for non-medical reasons. And the other thing we're waiting to see, and I suspect will happen, is excess waiting times. So if someone is waiting an excessive period of time, they can legitimately sue. And again, that's not really been tested in court. So I thought I'd very quickly summarize the sort of recent significant cases and how they impact on bariatric surgery. And I've mentioned Montgomery. I think we all now know about Montgomery and the case. Basically, the impact of Montgomery has not been as much as we thought it would be. Montgomery, for those of you who don't know, was a case involving informed consent for a woman who was having a baby who should have had, well, she felt she should have had a cesarean section. She ended up having a vaginal delivery, and the child ended up with shoulder dystocia. The long and the short of that case is that the old-fashioned notion that basically if you consent the way your colleagues consent, that's reasonable, has gone out the window. And now the test is, what would a prudent patient want to know before consenting? So that's a real summary of what Montgomery did. Now, ironically, that's actually what the GMC has been saying for 10 years. So although when Montgomery was published, everyone assumed there'd be major changes. Actually, I don't think it's affected our practice as bariatric surgeons much. All it's done is basically encase the GMC recommendation into law. But this case, which has come out from 2014, is, I think, more interesting and may have potential problems. This is Jones versus Royal Devon. Now, Jones was a patient who needed spinal surgery and was booked in to see a surgeon in Cornwall called Mr Chan. Mr Chan was away on holiday, and the patient was admitted and was actually ended up being operated on by his post-CCT spinal fellow. The patient ended up with a dural tear and complications and sued. And it was held that the failure to provide the named surgeon, because she said she went to see him, she was seen on his clinic and put on his waiting list, and the failure by the trust to provide that named surgeon invalidated the consent. Not only that, they actually said that that invalidated consent, therefore, even though the complication that the patient suffered was a reasonable complication, it wasn't due to negligence. Because the consent was invalid, all of the consequences that flowed from that in this particular case meant that she was able to claim compensation. I think that's a major implications for hospitals like ours, where we pool our patients, so someone is seen in clinic and then put onto a pooled waiting list. And it also has major implications for trainee cases. So on the logic of the Jones case, if someone was seen in clinic and you let the trainee do it, even supervised, and there was a complication, it could be argued that you've breached the consent, and therefore any complication that follows is automatically paid out. Hasn't been tested as yet. That's the only case, and there's quite a lot of debate about this. But that is the logic of Jones versus Royal Devon. And another case which has got some interest, but I think will probably be of quite relevance to bariatric, was Darnley versus Croydon Health. This is a case of a man who basically collapsed and banged his head. He went to A&E and asked how long he'd be seen, and the receptionist said, oh, it'll be at least 5 or 6 hours, at which point he said, forget this, I'm going home. So he went home, had a catastrophic bleed, and he ended up with a paraplegic. And it was held in this case that the receptionist who gave him that advice, which was erroneous, was therefore liable, and therefore the hospital was liable for the consequent damage. What that means, of course, is that if we have people, CNSs, admin staff who tell patients to wait 2 hours, 3 hours, or a year for bariatric surgery, and the patient says, I'm not waiting that long, and that is found to be wrong, we as a hospital, or we as a department, could be liable. So what I thought I'd do is, these are all very interesting legal points, but what I thought I'd do is give some case presentation and ask the audience and colleagues about what their thoughts were. Now, what I've done is I've deliberately changed the details of these cases, more to analyse the principles. An awful lot of these template cases are still being discussed, so there's no right or wrong answer to this. We still don't know the answer. I'd be quite interested to hear what people's thoughts were on it. So, first case I'd like to talk about is a 35-year-old with a BMI of 42, self-referred for private surgery. She was seen in clinic and she was offered a laparoscopic sleeve gastrectomy and was booked in the waiting list 3 months later. She wanted to go away on holiday before she had a surgery. About a month after a clinic consultation, she recontacted the surgical secretary saying she'd been on the internet and had heard about this banded sleeve gastrectomy. And apparently that was really good, and apparently it prevented weight regain, and that's what she wanted. The surgeon said, fine, arranged another consultation with the patient, talked about this operation, and agreed to do it with a £1,500 uplift. The Patient had surgery, and you probably know what happens next. 10 days following surgery, presented to local A&E with severe sepsis. There was an urgent transfer to the local bariatric service, and laparoscopy revealed a perforation under the band. It was a phobia ring. So basically, there was a perforation of the staple line under the phobia ring in the mid-portion of the sleeve. So the ring was taken out. She had a post-operative stay in ICU for 2 months. 2 months total hospital stay, and she's got peripheral neuropathy following her ICU stay. So, letter of claim was submitted by the patient on behalf by the solicitor on behalf of the patient, and they made multiple allegations, including the following. They said that the consent was inadequate, and specifically the surgeon was inadequately experienced in this operation. This was a novel procedure, and it shouldn't have been offered at this private hospital, and there was certainly no evidence of any novel technologies or novel committee approval at this private hospital for this banded sleeve. The very fact that she had a leak was evidence of a substandard technique. And in support of that, they unfortunately got the surgeon's website, which said, "I have never had a leak from a sleeve gastrectomy to date." And they said, well, if he's never had a leak before, he says he's done loads, and now he's saying he's had a leak, clearly something's wrong, and had a standard sleeve been done based on his own advertising, you would not have had a leak. You've done something odd, something different, which you shouldn't have done, and that's why I've had a leak. So the response to the letter of claim was that the consent had been specifically obtained, so they had a specific consultation where they talked about it. The surgeon had previously performed a band on a bypass, a phobia ring on a bypass, as revision procedures, but critically, he hadn't done it at that private hospital, and he had never done it on a sleeve and had never done it as a primary procedure. But he said he was capable of performing the procedure, he had the technical ability to do it, and that leak was a recognised complication which was well managed. So I've changed some of the details, but this is a real case which is actually actively ongoing. I've deliberately changed the details, but the questions which I think it raises is this, and I'll put it to the panel and to the audience itself. So first thing is, do we regard a phobia ring on a sleeve gastrectomy as a novel procedure? I'll start with Sanjay. What do you think?
Yes, I have never carried this out, and I certainly haven't seen lots of series of these, and these are not things that we routinely offer any patient.
Marcus, do you think it's novel?
I think that the individual components are not novel, but combining a procedure such as this is novel.
Any thoughts on that? So should the surgeon have said this is a novel procedure which cannot be done in a private hospital? That's the question.
Is he doing it in a public hospital?
He's done phobia rings on bypasses as revisions in a public hospital. So that was his argument. He said, I've used phobia rings in bariatric surgery, therefore, what's the deal?
A number of NHS hospitals now are bringing in something what they call it a novel procedure committee. So in other words, you're able to even make adjustments from, let's say you are going to do an RY bypass before, and now want to do mini gastric bypasses. That has to go to that committee. So they actually haven't done it in that modification. So well, this is not a commonly accepted procedure. So yes, it would be another procedure. And if you're going to do it in that hospital, there should be a procedure.
Well, the private hospital turned around and said, we don't have a novel technologies procedure. We rely on the surgeons and their own competence. And the surgeon says he's experienced in doing phobia rings. He knows the technique. He's an experienced bariatric surgeon. He does not feel it's novel. It's not new technology. It's just a change of a technique that he is happy to do. And therefore, we did not feel it was appropriate to have it assessed as a novel technology. What's the thought on that? Yeah.
I think in today's age, you've just got to be open and honest. Say, you've done this procedure in these cases. I have not done it in a sleeve. Would you like to do it?
Okay. So the next question, which leads me quite nicely to the next question. There's quite a lot of toing and froing about what the surgeon had actually done. And there was lots of, I've done lots of sleeves, I've done lots of bypasses, I've done lots of revision, I've put lots of phobia rings on. But it turned out that although he had done a reasonable number of phobia rings, he had never put a phobia ring on a sleeve. And the question is, in the consenting process, was he duty-bound to tell the patient? Now, he said he told the patient it was rare. He said he told the patient there was limited long-term data on it. This is all documented. He said that no one really knew. He said it was novel to the UK. But the question was he duty-bound to say it's the first time he had ever done it on a sleeve, or his contention was, I told them I'm experienced in Phoebe rings, this is unusual, this is rare, but I'm happy to do it. Is that enough of a consent?
So quick question here, do BOMs, because this is case you say from UK, do BOMs as our council have these procedures, let us say these 6 procedures can be done for anything new, we have to ask permission? Should we not come up with something like that then?
We have
Like
Peter
this,
and
so
we know Richard. Perhaps they can update us. What do you think?
then
Peter, we know the
like
Richard.
a BOMs and those things. You know, like the IPSO has, let us say, 10 procedures and those. Should we have as a nation that these are the, what are the advantage and disadvantage in doing that?
This is a private hospital, and a private patient who's researched and is motivated to get an operation, this is what the surgeon's saying, which I am capable technically of doing, and I have experience of Phoebe rings, and the patient wanted to do it, it's a reasonable thing to do, it's putting a bit of plastic around stomach, which I do when I band my bypasses. Why is this different?
So Omar, in the past, it was easier to get away with this argument. It is not anymore, because the question nowadays, the criteria, the test is that it's not you only, the whole team. Does have you actually looked at the possible complications? What's the instances? Are you recording it in the registry? Because in the NBSR, we haven't got a banded sleeve option, so it will not be recorded as such. Is it? Okay, well now I stand corrected. So I've never done it. And then the third option, of course, is the question is whether the team knows how to manage. In our case, as you know, in Whittington, where we were criticized for our balloon perforation, it was that the radiologist did not know that the balloon can cause a gastric outlet obstruction. And so it is the hospital that the hospital know if something goes wrong.
Can I just ask a question of the audience? How many people in this room have done a banded sleeve? Okay. There you go. So the majority of people here don't do it.
So I suppose the question is as well, was the presence of a leak in itself suggestive of an inappropriate technique?
Sorry, say that again.
Was the fact that you had a leak, is that suggestive that the surgeon didn't know what they were doing? Because the letter of claim is very clear, because it's done by solicitors, and they're saying, you've put on your website you've never had a leak from a sleeve. Miraculously, this is the first one you've had, and it's a technique that you've done for the first time. Clearly, this is an inappropriate technique, because this shouldn't happen. What people thought of that argument. Yes.
So, as probably the only non-surgeon in this room, I've been here 2 days and I've learned something. That a sleeve is a high-pressure system and a raw Y gastric bypass is a low-pressure system. So you can put a band on a raw Y gastric bypass because it's a low-pressure system. And I see the leaks and I see the complications. So if you put a band on a sleeve, you're making a high-pressure system even higher. And if you don't get a leak, then you're doing very well and you're very lucky to get away with it. So to me, it looks like a completely inappropriate combination of techniques.
But
and I'm not even a surgeon.
But it is established, and people do it.
The reason you're not a surgeon is you don't understand.
I'll go there.
It's not nothing to do with the pressure.
Okay.
It's not to do
The
with
ring is
pressure.
there to stop the dilatation.
Yes.
In the immediate post-operative setting, the risk of the staple line breaking down is at a higher risk if you've got a high pressure system.
Slow.
I mean, it's debatable, but the argument is, I don't think anyone is saying that a banded sleeve is a negligent operation per se, because it is described in the literature, it is there. The question is, should this
Omar,
person do it?
can we just take a view from Slope, please?
Yeah, so,
And then,
so this is a medico-legal session. So let's say, if this particular surgeon said that, okay, I'll be honest with you, I haven't done sleeve with a band on it, but I'll get somebody who's done it, and he's gonna mentor me or do preceptorship for me. On the first case, what would have been his medico-legal stance there if he leaked afterwards?
I mean, there is no right or wrong answer to this. This is, I mean, there is no, unfortunately, there's no tablet of stones. Most of these cases are actually settled before it actually gets to the point where a court has made a decision. But eventually we'll get to a point where it won't.
Yeah.
But that is a very fair question. Marcus, what do
I
you
mean, the
That's an important point. I think we would have first be make the movie in the theatre.
I think that's what you would do with any so-called novel technology. You need.
I think that this case will fail on many levels. So firstly, there's a degree of weakness from the point of view of this not having been discussed as a fairly novel procedure. So there's some weakness there. There's weakness in the consenting process, because with Montgomery, if you put yourself in the prudent patient's position, so the reasonable patient, that patient, so Omar mentioned the prudent patient, actually it's that patient specifically. And that patient in her, after this complication, when they're asked, if you had known that this was going to be the first time this surgeon had done the operation, would you have chosen? You can guess what the answer will be after they've had this leak. It'll be, if I'd known, I would not have had this operation. So we've got a failing in the consent. So that's why most of these cases will be settled beforehand, because Montgomery's changed the consent process. In this situation, there's some weakness towards whether this was or wasn't a novel procedure, but there was no even discussion on whether it was. So you have to ask the question within your hospital institution, is this a novel procedure? So that happens in the NHS too. Sometimes they'll say, no, we would not consider this novel. So this is very weak on many levels. So
I think
that's why they're settled.
We'll take two more points, then we'll move to the next one, so I appreciate the dial. Yeah.
As a chemical pathologist, I just want to comment that there could be multiple contributory factors towards the leak, and like Dr. Shidrati just said, it's surgical and medical reasons. But it could also be because of the nutritional status of this patient, especially like metalloproteinases, which are important for healing around the suture line, and the balance of those, which can be important in vitamin D deficiency, zinc deficiency. So that would have even contributed towards poor healing of the suture line.
Terrific.
I just want to talk about earlier on the discussion between whether we should accept it in written, what are the list of procedures being done. If so, we are parent body has accepted banned as a procedure should be done. So there's no point for discussion on that. But the discussion, particularly in this case, is whether this surgeon not done one before, attempted one without any mentorship or any training, that's where it fails.
So if the leak is at the point of where the band is, this is hydrogen injury at the time of.
Who knows? Who knows?
Does it qualify as a leak? Hydrogen injury?
So the second case, I thought I've got one more after this, and I appreciate lunch is calling. But the second case is 54-year-old male, BMI of 48, referred to for NHS surgery, and he wanted to see Mr. A because his brother had had bariatric surgery under Mr. A in a large teaching hospital trust, and he very much wanted to go to that same hospital because his brother had had a fantastic result. So he was seen in clinic, offered a gastric bypass, and placed on the waiting list under Mr. A. So unfortunately, waiting list being waiting list, time marched on, and at 11 months after he'd been placed on the waiting list, he was phoned up by the administrative staff at the trust and offered surgery in another NHS provider, which he said yes to. He met his surgeon, Mr. B, at the other trust on the day of surgery, had the procedure, it was carried out as a rheumatoid gastric bypass, discharged after one night. Unfortunately, 3 days later over the weekend, he developed abdominal pain and went back to that hospital. He was admitted under the surgical team, had a CT scan which showed free fluid in the abdomen. So the on-call consultant surgeon was Mr. C, who was a breast surgeon, and he attempted to contact Mr. B, but there was no reply. So given the patient was unwell, he did what he did traditionally. He did a laparotomy, found a small enterotomy in the alimentary limb, which was easily visible. He sutured it and put some drains in. The patient went back to recovery and then to the ICU. Unfortunately, then developed an abdominal wall dehiscence. The abdomen was then resutured, but he had a prolonged hospital stay and ended up going home with a big incisional hernia and is now awaiting abdominal wall reconstruction. So in the letter of claim, they basically said that the transfer was coerced because the patient was told, you're about to breach, we're going to offer you another provider. If you turn this offer down, then I'm afraid you go back to the bottom of the waiting list. This guy had been waiting 3 years in total for surgery, for tier 3, etc. So they said that the transfer was coerced by the trust. The consent by Mr. B on the day was inadequate because Mr. B had only seen him for the first time then. The absence of the on-call bariatric surgeon in the other trust was negligent. And their overall summary was, had the original trust not broken its duty of care in providing timely surgery in its own institution, the patient would have potentially avoided the complication, or on the alternative, if he had had the complication anyway, he would have been readmitted to the big trust and had a laparoscopic washout because there's an on-call bariatric surgical service there, and therefore avoided the incisional hernia. So I think this raises quite a few issues, and the first is the trust negligent in failing to offer surgery within the host institution within 52 weeks? Is that a breach of duty of care? Sanjay, what do you think?
Which one?
Mr. Director.
I think it should be answered by the managers rather than by clinicians.
Well,
Mr.
the thing is, they sue the trust. They sue the trust. So the question is that a failure? Now, you could say, and in backup evidence, they said there are clear statements about the 18-week RTT time, and also at 52 weeks you get fined. So clearly the government thinks it's a major issue. To fail to achieve that 52-week target is a clear breach of duty. The other way of spinning it was the trust said, we appreciate we've got capacity issues, but we acted. We acted by arranging a transfer to another bariatric unit. So you can't say we breached our duty. We did what we could. We can't help the fact we don't have the beds, but we actually offered the patient another option.
So I looked at the situation, something similar about a couple of months ago. There was a test case in Wales where a patient was denied a procedure, and the patient took the CCG or whatever equivalent in Wales to court, and eventually the court, even though the initial finding was in favor of the patient, the court argued, the CCG argued successfully that they had dual responsibility. One is that they have to follow NICE guidelines. The other was their fiduciary responsibility so that they don't get overspent. They have to remain within the budget. And therefore, on the basis of that, the court took the view that it was the right thing for them to deny, even though the NICE had recommended. So I suspect that this is what the trust will take here and say that because they have to balance their books and they can only provide so many, so they're breaching. So I suspect that that's the look that they will take.
I think the trust were a bit more generous than a bit less hardline. They took the view that if we hadn't operated within 52 weeks, we'd probably accept we had breached the duty of care. But we knew we didn't, and we gave an alternative option, and therefore it isn't a breach of duty of care. What do people think about that? Is that reasonable? Not reasonable?
Yeah.
All right. So the next question which was asked was, Mr. B, was he negligent in his consenting process? Now, the other trust turned around and said, we only took this patient on the basis this patient was worked up and ready to go and was on your waiting list and could have been called in at any day. So Mr. B was like another member of your staff, and their point was this trust pooled patients. So they said it was ridiculous that it was on Mr. A's waiting list, but it could have been done by a different surgeon in that hospital, and the first time they'd see him would be on that day. So what was the difference? Any thoughts?
Had he been consented beforehand?
He had gone through the consenting process in clinic, but he hadn't signed anything.
So had been through the consent form.
Yeah.
If he'd been through a consent form and that had been signed by the surgeon at the time, when he came to see Mr. B, he would have been asked, should have been asked, have you any consent to that? And that would be obliged. But if he was given the consent form on the day by Mr. B, then that is negligent.
The argument advanced by the other trust was they only took these patients on board on the proviso that these patients were worked up by the trust and ready to go. And their argument was the patient's care would not have been any different had they been stayed in the same trust and seen a different surgeon through pooling. So the question also then became, was the second trust negligent in not offering a dedicated on-call bariatric service? And allied to that, was the host institution who sent them across negligent in not assessing the facilities in the second trust? One of the arguments made by the claimant was they wanted to go to this big teaching hospital because they knew they had an on-call bariatric surgical service. And the big teaching trust promoted the fact on its own website that they had an on-call bariatric surgical service, which was 24/7, and any problems, there'd always be a bariatric surgeon in town. So if the trust, the teaching trust is saying it's an important thing which they're promoting, surely if they send their patients away, they have a duty to check that the same standard of care would be applied to the trust they're sending their patients to. Any thoughts?
Question, how many trusts in London has got on-call bariatric dedicated? Just tell me, I don't think there is one bariatric paid bariatric surgeon on-call.
There is, but most units would have a...
No, we cover a ad hoc, but we don't have a bariatric, at least not in Homerton. We don't have a bariatric service on-call 24 hours, 7 days a week.
Do you have a GI surgeon?
We have colorectal surgeons who does, but they call us if there's a necessity, but we are not on-call on that day.
But the question
I'm
was,
not sure about St. George's or other places in London.
But Sanjay, isn't it right that we have got, all hospitals have got processes? So if a chest trauma turns up in my hospital, there is a process.
Yeah.
If there is a liver problem that turns up in this hospital, I'm sure you have got a process, whether it goes to King's or Royal Free. It's not that the
But
first
that's where the question comes. Is there a bariatric on-call in London any other way where we can send the patient if there is a colorectal surgeon on-call on that day? Is there a hospital on-call?
well, the question then becomes, was Mr. C negligent doing a laparotomy?
I mean, if he's right in that the patient should have been transferred to a dedicated therapeutic centre, that it probably shouldn't have been treated in the centre.
Absolutely, but the question is which hospitals in London do provide that service?
But the
Or a bariatric centre, which the original post institution should have provided.
Well,
so they would have run us.
But the argument which was used by the trust was, as a breast surgeon on call, he tried to find a bariatric surgeon, Mr. B. The patient was an extremis and peritonitic, so he did a safe laparotomy. But of course, the other way of spinning it is, had he gone to the had he been in the host institution to start with, it would have been a laparoscopic surgeon seeing him, done a laparoscopic washout.
But Omar, what I probably did not make it clear is that if there is a problem in the trust number 2, has the trust got processes of transferring this patient to the appropriate unit if there is a problem? That's the question.
No, but that's not the point.
But they haven't tried because this is not a system. So if they had a system, if you have got a system, let's say that you get cholangitis in your trust, and you have got ERCP, you have got a system as to how this patient goes. You've got a gallbladder, patient comes back, cholangitis, you have got a system where to send this patient to. Has this trust got that system?
Yeah, they don't have a formal on-call bariatric surgeon. Yeah.
So Peter, I think we're missing slightly the point here. The bariatric surgeon who's on call for emergencies tries to get a bariatric surgeon for help. He doesn't get it. He realizes this patient is an extremist. This person, if I don't do something, which you and I would probably be faced with. If we have a liver trauma, we have to face it, and we have no help. We will go in, and that's exactly what he's done.
Yes, no, I agree, but the
breast
surgeon is not liable. What we're talking about here is the institution. Is the institution liable that they don't have the system? They're taking on the work. Now, if you take on the work, you have to accept that sometimes things will go wrong. Having all the processes to deal with when things go wrong. That's the point.
Well, I've not seen the argument go to court, but I have seen the argument in the coroners where the coroner instituted statutory enforcement that all bariatric patients should be accepted by the host institution. This was only in one individual unit. So I haven't seen this go to court, but if you operate on someone as a bariatric patient in that centre, they are now obliged to take back their patient.
Just ask the audience how many people do a dedicated bariatric on-call service. Just ask the audience. Show of hands, please. Who's got a 24/7 bariatric service in their trust?
7 days a week.
24/7. Who's delivering that service?
Only UCLH and Taunton. Anybody else?
But I think another question to ask is how many places have an informal cover of bariatrics for their own patients? Because that's relevant for electives. It's an elective workload primarily.
So I think collectively, do you think this case is defensible?
I don't know, you didn't mention the one issue, which I think it always crops up in the Medicolegals, is the enterotomy.
The enterotomy?
Wasn't there an enterotomy?
Yeah, there
yes.
was. There was
No, there was a leak. There was a leak.
Oh, it was a leak.
It's just
Right,
a leak.
that's
It's just a
different.
pulse bypass leak. There was no suggestion that there was a there was a small enterotomy, but there was no suggestion that was negligent. It was felt that was delayed, and for some reason they decided not to talk.
I mean, leak is very different to enterotomy. Yes.
So I'll do the last one before we get to lunch, which is another interesting one. 45-year-old lady with BMI of 60, referred for bariatric surgery due to extreme obesity. Had initial NHS assessment, and at that assessment was told it's going to be a really long wait, and I know you're very big, but at least a year. So she went back to a GP and basically said, look, I've got money, at which point the GP said, fine, why don't you think about going privately? I'll arrange that. So the GP wrote a letter to a private surgeon. She saw the private surgeon. During the consultation, she stated she had recently been an inpatient in the psychiatric unit, but had been discharged. And she said the psychiatric unit are really happy with her. They've discharged her. She's in the best place she's been mentally for a long time. They're really supportive of going ahead with bariatric surgery. And the GP letter said she was extremely obese, high risk of cardiac complications, and needed surgery urgently. So the private surgeon sent her to see his bariatric counsellor and his bariatric dietitian, and got letters back from them saying basically she was motivated for bariatric surgery. She was in the best psychological state she'd been in for years. And there's a comment saying that the psychiatric services apparently were supportive of bariatric surgery. So she underwent the sleeve gastrectomy, represented on day 5 with a query leak. Laparoscopy revealed a proximal leak for the sleeve, and stents were put in, and then she was drained. She had a prolonged period of hospitalisation, and during that period became very down, and unfortunately had recurrence of psychiatric complications with psychosis and psychiatric deterioration, resulting in readmission to the inpatient unit she came from. So a letter of claim was sent, and basically the complaint was that the patient's psychological assessment was inadequate. And when you looked at the actual psychiatric services, there was no formal assessment by the psychiatric services, which she was admitted under, about mention of bariatric surgery, and no mention of support. There is lots of entries in the psychiatric notes saying she needed to lose weight and that would be good for her, but no formal mention of the fact that she was having bariatric surgery would be a good candidate. The other criticism was there was no minuted MDT meeting or discussion about what the outcome was and why she was going ahead with surgery. And they posited that no reasonable MDT would have proposed surgery so soon after hospitalisation in the psychiatric unit. And had surgery been postponed, she would have been in a better psychological state to tolerate a complication and therefore not had the mental health sequelae. So the response was as follows. The surgeon wrote back saying that in a typical private hospital, and we have to compare like with like, most private hospitals do not have a formal MDT structure. She was seen by members of the MDT. Although she wasn't seen by a psychiatrist, she was seen by a bariatric psychologist or counsellor who felt that she was in a good place. She had an incredibly high BMI, which meant no MDT would say that there was any other reasonable option for this woman other than bariatric surgery. And they also said it was unreasonable to foresee that she'd have A, a rare complication, and then B, that rare complication would lead to an even rarer complication, recurrence of a psychiatric condition. So the questions to be asked are, was the surgeon negligent in relying on a bariatric counsellor as opposed to a psychiatrist for this assessment? Bear in mind, this is the private sector. So, Sanjay P., what do you think?
So I think that this case is quite worrying. And I think that Marcus was asking me what I do in my practice. So I have a psychologist and a dietitian, and if they have any medical issues, a physician, and we discuss the patient, and a letter is written, which is an MDT. Yeah. So I think there is negligence here because this is clearly there is psychopathology and significant psychopathology in this patient. So they should have seen a psychiatrist.
So the question then, which has now been raised, is who was negligent? Was the surgeon or the bariatric counsellor obliged to contact the psychiatrist or ask for a psychiatric opinion? Because as a surgeon, even though the bariatric counsellor, who is a psychologist, has said that she's in the best psychological state she can be, the psychiatry services are supportive of her going ahead with surgery, and she has a BMI of 60, which means her chance of, say, sudden cardiac death is very high, and the GP has asked to have to be seen privately because he's worried the weight will be medically detrimental to her.
I have been in a situation where I had to go to coroner's court. One of our patients died, and I was in a very uncomfortable situation. And the only way we got it, even though this patient had been discussed in front of an MDT, and there's a jury, but because we had 2 psychiatrists consultant independent written reports, that was considered sufficient. So I think that it will be very difficult nowadays. If nothing happens, you're lucky, but if patients have problems, if it goes to court, if a jury...
Okay, spinning it around another way, what would an MDT have done then? Because there's psychiatric support to say, no, she didn't need any intervention at that stage. There was no drug they'd give her, there was no CBT. She had the gamut of investigations, had been discharged by the psychiatrist, and been told she's in as good a state as she can be. Sorry. I will come. You had a hand up first.
I wouldn't. I say it's a joint. Both right psychiatrist, but I think the surgeon probably should contact the psychiatrist. She had a recent inpatient stay. A bariatric counsellor is not there to assess the patient's psychiatric illness.
So I think both have an obligation, but I think surgeons has to do it.
So you're
I want to point out that I've come across situations like this with patients that we all have. And our experience often is that many psychiatrists would say, oh yeah, the patient will do very well. And one wonders how much psychiatrists understand about this particular kind of problem. So is the advice that the surgeon goes from the psychiatrist the correct one?
Is there a psychiatrist here? Do you have any psychiatrist?
I totally agree with the comments, and I think we should have a policy. If somebody has had a recent admission, I think the best thing I think would be to at least observe for a period of time to have a further assessment by another psychologist or the patient psychiatrist or the psychologist involved with MDD decision. So I think if there is no such policy in place, it's difficult, but perhaps the recent admission is a red flag.
But what the other side are saying, the private side are saying, is that what do you gain by waiting? There was no psychiatric intervention which could have been done. And if she had had a heart attack in that period, given the GP had referred saying this is medically urgent, in his view, would we then be sitting there saying she should have had surgery earlier?
Well, if there is a patient has suicidal tendency or...
There was no suicidal ideation. She was in as good a place as she can be. Well, the psychiatrist had discharged her. That's the point. That the surgeon saying the psychiatrist had discharged her, saying she's as good as she's going to be. There was no intervention. The psychiatric expert didn't say, if only they'd given her this drug, she'd be better. The psychiatric expert said they'd done everything they could. She was as good as she can be.
I think the way the comments are, it sounds that they should never be seeing a psychologist, because that question is always raised that, oh, it's a psychologist who has cleared it, we need a psychiatrist. So does the psychologist opinion value here? Because as Omar has clearly mentioned, the psychologist is safe to proceed.
Yeah.
Chair, do you think that the key here is recent inpatient and
I think we'll have to carry this over into lunchtime and discuss it over your baguette.
Can you just wait?
We're pushed for time. Thank you.
Thank you, Marcus. Can you just wait, please? Don't go away.